Well, hello everybody and welcome. Today we are going to start our review about tuberculosis, medication for tuberculosis, and antineoplastics. All right. So first of all, talking about tuberculosis, tuberculosis is a preventable disease. What we are going to talk today are basically about the therapy. But for this, we need to talk about something general. The essential for diagnosis of tuberculosis is going to be very some symptoms that we are going to talk a little bit. The first one is going to be fatigue. Fatigue. The patient is going to feel loss of weight loss. Especially what is characteristic of tuberculosis is they have night sweats, and coughing. So we have night sweats, some fever, night sweat fever at night, okay, and cough and fatigue and weight loss. So what they are going to start happening that mostly the Mycobacterium tuberculosum, that is the bacteria that produce the tuberculosis, they are going to mostly invade the lungs, but they can affect other areas of the body. So what is indicated here is that to take an X-ray to see if there is some infiltrations. Infiltration means inflammatory areas in the lung. Of course, they are going to have a skin test that is the tuberculin, and the tuberculin is the same to say the PPD. And the vaccine for tuberculosis is the BCG or Bacillus calmette-guerin. So these are BCG. All right, so nursing considerations about tuberculosis treatment is the LFT. So what is in general for all the um, medication for tuberculosis is to check the kidney and the liver. Number one, liver. Number two, the kidney. So that's why we will talk about LFT studies. They can be repeated about 1 or 2 weeks, every 1 or 2 weeks. And the renal profile, that is the Chem7, that is including the BUN, the blood urea nitrogen, and the creatinine, plus the sodium, chloride, etc., and glucose, that is part of the Chem7, just to check the renal profile, how it's functioning, especially BUN and creatinine. Okay, so urine color, always check for a intense yellow color. That is before the treatment, okay? Because if the patient is having some liver dysfunction, that is going to be a problem if you are going to give the medication for tuberculosis. Jaundice. So the coloration of the skin, yellows, and the skin, sclera, etc. And please, no alcohol. It's totally prohibited, the alcohol with patients who are receiving treatment for tuberculosis. Just remember, again, very important, the treatment is minimum about 1 to 2 years. So 2 years is the mostly for systemic tuberculosis, because tuberculosis affecting the lungs, but what happens if the patient is not treated? The tuberculosis start to invade other areas, especially bones and nervous system. So this treatment is need to be given at the same time every day. And sputum. Sputum is the secretion of the respiratory tract that we will send it to culture in order to see if there is a presence of the bacillus in the specimen. Okay. All right. So one thing is the well. All right. So that is about the general things about treatments. So let me keep going. Okay. So the sputum cultures. That is what I want to remark. We have the cornerstone, and open eyes, open ears here, the cornerstone of all the treatments of tuberculosis is going to be isoniazid, INH. And the main thing of INH, as we reviewed before, is that consume the vitamin vitamin B6, that is the pyridoxine. The deficiency of pyridoxine is going to produce the neuropathy. So in any of the treatments that are going to be prophylaxis, okay, or is going to be for long-term treatment, you're going to receive isoniazid. And for isoniazid, the main side effect is going to be the neuropathy. The neuropathy start with paresthesias. Paresthesias means numbness. Okay? All right, so isoniazid can be alone or can be with rifampin or can be with pyrazinamide, but remember, cornerstone medication. So without isoniazid, there is no treatment for tuberculosis. So always need to give it with isoniazid. So the first line, we have the rifampin, the isoniazid, the ethambutol, streptomycin, pyrazinamide, and the para-amino salicylic acid. So it can be given this one or this one either, but always isoniazid. And here we have just a mnemonic that we already went to in class that is called PRIST. PRIST is R, rifampin, isoniazid, ethambutol, and streptomycin. Streptomycin, let's start with this. Streptomycin is aminoglucoside. Remember, aminoglucoside family, we have the gentamicin, streptomycin. We don't use gentamicin for tuberculosis, we use the streptomycin. And obviously here you can tell that all these medications, please, have a common side effect that is the LFTs. So you need to be careful with LFTs, they can be elevated. Streptomycin as aminoglucoside is nephrotoxic, right? It's nephrotoxic and ototoxic. Remember that. All right, so let's start with pyrazinamide. The pyrazinamide is going to be in tablets. You need to remember that we give the same time every day. Even if there is some side effects, you still needed to take the medication. And why we give so many medications, by the way? Remember, open eyes, open ears again, we use a combination of all these medication because it's mycobacterium that is the bacteria is the enemy. The enemy can result in resistance if you give one or two medications alone. So that's why they giving a combination. So we try to kill the enemy from different angles, in different ways, in different mechanism of action of this medication, so we are successful in order to get rid of this bacteria. So all the anti-tuberculosis medications are going to be anti-tubercular medications who have LFT values always, 1 or 2 weeks lab test, okay? They are going to increase the uric acid, the pyrazinamide. This is a bout of gout. So how we can check the bout of gout is some pain on the articulations. For example, if I have some pain on my toe or my pinky finger, whatever. So those can be because an increase of uric acid levels, bout of gout. Okay, rifampin is they are going to produce the, let me see, is going to have side effects, rifampin, and please, that they can have, can lead, the urine can be reddish orange. So we just remember reddish, but it's reddish orange. So don't be careful with that. And just remember, rifampin, no, it's red, right? So reddish orange, rifampin, RR. Another thing that we must remember is that rifampin is going to decrease, go down. The effect of what? COW-D, rifampin, COW-D. Corticoids, OCP, oral contraceptive pills, the warfarin and the digoxin. So many medications produce the increase of digoxin, but in this case, rifampin is going to decrease the effectiveness or the effect of that digoxin. So what we need to do is, in this case, is the patient is receiving this medication, they are going to increase the dose of corticoids, OCP, warfarin, and digoxin. I'm sorry, OCP, we don't increase medication. OCP, we need to check for another method of contraceptive, okay? So just remember, OCP is going to decrease the effect of the OCP, so we need probably to change the method of contraception. Corticoids, we need to increase. Warfarin is going to increase. As soon as the patient is finishing the treatment, the warfarin levels should be lower. So you actually, they're going to we need to lower the dose of warfarin, and the same from digoxin. Okay? Again, very common for everybody, hepatotoxicity. All right. So, and the pills coming in red. So that is actually the presentation of the rifampin. Isoniazid, we have, that is the cornerstone of the medication. So always, so please don't forget about this, the cornerstone of isoniazid. So always you're going to have these side effects. We have the peripheral neuritis, that is peripheral neuropathy, peripheral neuropathy. That is because the nerves, they need vitamin B6 to repair and maintain the nerves. So if they are not repairing or maintaining, and they're not repair, they are going to just degenerate. And that can lead into what we call peripheral neuritis. So that is nursing. The nursing considerations is, first of all, to tell the patient, if the cornerstone, the patient is always receiving isoniazid, so educate the patient to tell you if you have some signs and symptoms of peripheral neuritis. Number one, so what are those? Are going to be the paresthesias, okay? It's going to be numbness, especially on the distal portions of the upper and lower extremities. Those are the areas that are going to mostly have more incidence of this. So vitamin B, second is the vitamin B6 supplements, right? So supplements during the time that the patient is taking this medication. And other things are going to be the tyramine. The tyramine is mostly what can cause redness, itching, flushing, sweating, tachycardia, headache, or lightheadedness. So there's minor side effects, but NCLEX, they like to ask sometimes about the tyramine. Tyramine, why? With parentheses here, because they can interact too with another pathology. That is, for example, we have the Parkinson, the MAO inhibitors. The MAO inhibitors are going to interact with the tyramine. So tyramine is can be a source of many questions. Passing the page or returning the page to tuberculosis. So please, no Swiss cheese, fish, tuna, or foods containing tyramine. Okay? Tyramine is a product of the tryptophan. Tryptophan is an amino acid. Okay? Okay, so again, so we are talking about the isoniazid is going to be the hepatotoxicity, right? Hepatotoxicity everywhere, all these medications. All right, so here we have the patient education. If you're tingling, numbness, okay, paresthesias, right? Paresthesias are actually same to numbness. And we have another one. Is a little bit too early to talk about that, but phenytoin is anticonvulsant, and it's always typically question for NCLEX. Phenytoin is anticonvulsant, and what is doing the isoniazid, phenytoin, isoniazid, isoniazid is going to increase the effect of the phenytoin. So here we have the side effects of this effect of increasing the effect of phenytoin can produce this. I'm not going to mention because it's not part of tuberculosis, but it's part of anticonvulsants. Okay, so but definitely this is a high yield for NCLEX, phenytoin and isoniazid. INH. So remember phenytoin, IMH. So just to remember that. Ethambutol is, again, all these guys are going to be in tablets, by the way. So ethambutol, we have is the miambutol, and the miambutol is going to produce some side effects. Like, for example, I will go here, we call visual acuity, visual acuity, decrease visual acuity. So I should be putting here in red. And we have optic neuritis, okay, optic neuritis. What here is just a fundoscopy, and this is abnormal. So we see here the optic disc where it's coming the nerve, and there is vessels, and we know that there is neuritis because these vessels, this is probably normal here, but here is dilated. So that's why we call neuritis. So that can produce blurred vision because of this edema. So vasodilation produces edema of the disc, and that is going to produce some swelling there here that is going to disturb the visual acuity. So that is about optic neuritis. One thing that we need to remember is the red-green vision changes. So they can change the red-green vision changes and the other one is the we talk about pyrazinamide, right? Pyrazinamide at the beginning increase the uric acid. So ethambutol is increasing the uric acid. So pyrazinamide, ethambutol are going to increase the uric acid. All right. All right. So again, we have the mnemonic priest. Okay, so I'm not going to repeat that. So streptomycin, we already talked about that, the side effects, the autonephrotoxicity. All right, so here we have the we have here the summary. So that is actually what we was talking in the previous class. So now let's talk about the cancers, right? Antineoplastics. Talking about antineoplastics, you have this view where you have the most common, the new, this is 2008, published in 2014, but the numbers are similar at 2016, and we expected the same, similar to 2017. So, but here is just to let you know the most common incidence of cancers are going to be breast, prostate, so breast female, prostate male. Second are going to be lungs, and third colon, okay? And the deaths, so deaths, if you see lungs is number of cases is number 3, but the number of deaths are going to be number 1. So that is telling you just that this cancer is very aggressive. All right, so here we need to talk about how to name some cancers. Epithelial cancers, epithelial cancers. So everything that is epithelium, right? What is epithelium? Epithelium is the lining of the hollow organs, lining of the arteries and veins and lymphatics, right? They are going to be the lining of the stomach, the lining of the esophagus. So all the linings are going to, and covers are going to be epithelium. Plus, don't forget about the glands. Glands are epithelium. So glands, for example, pancreas is a gland. So we have adenocarcinoma of the pancreas. So so you need to differentiate how to call the according to the procedence of the lesion. Connective tissue is considered muscles, yes, muscles, bones, ligaments, tendons, okay? And all these guys are going to be called sarcomas. For example, the cancer of the bone is going to be osteosarcoma. For example, cancer of the muscle is called the myosarcoma. Leiomyosarcoma, rhabdomyosarcoma, etc. The something to say here is that sarcomas are much more aggressive than the adenocarcinomas. But the adenocarcinomas are more common than sarcomas. Okay, lymphomas is going to be leukemias, and the treatment will be surgical. radiotherapy, and chemotherapy. One thing that I want to, well, let's talk about this first. All right, so we have the chemicals, the chemotherapies are being made in order to kill cells who reproduce very fast, and that is the case of cancers. So that is the case of cancer. So all the chemotherapy are chemicals that produce the death of cells that reproduce faster, very fast, and that is cancer cells. But this chemotherapy is not going to discriminate between cancer cells and normal cells. So they will kill normal cells and cancer cells. Which group? The ones who reproduce very fast. And in our body, we have cells that reproduce very fast. For example, we have the skin and hair. We have the lining of the stomach, and actually the whole GI tract slough. The lining of the mucus of the GI tract is slough of about every 3 days. It's changing. So the division of the cells are very fast, and very high. We have the bone marrow. We have the red blood cells. We remember that the red blood cells, we have every second we produce about 2 million of these red blood cells. So here we have skin cells that reproduce very fast, hair produce very fast, the lining of the stomach and GI tract reproduce very fast, the bone marrow, red bone marrow produce fast red blood cells, and gonads that are the ovaries and the sorry, what is this? Oops. Oh, what happened? Okay, and gonads that produce spermatozoids and the ovules, right? So to go to the point, we have that these cancer cells will destroy skin, hair, so you're going to lose hair. So there's nursing considerations, of course, for hair, right? Number one is you need to remember the radiotherapy and chemotherapy. When you receive radiotherapy, you are going to lose your hair, and you need to educate the patient. You need to tell the patient you're going to lose your hair, and there is some options for that, right? And after the radiotherapy, the hair most likely is not going to regrow in radiotherapy. Radiotherapy, the hair most likely will not regrow again. But in chemotherapy, you lost the hair, but it's likely that not 100%, but likely that the hair will grow again. And that is lack of hair is called alopecia. Stomach, if you have this slough of the cells very high, they're going to kill the cells, normal cells of the lining. They produce some irritation that increase the peristalsis, leading into diarrhea. One thing that is very important, diarrhea is very important. But other thing that is very important is the stomatitis. Stomatitis is sore mouth, canker, cold sores. So there's a lot of nursing considerations here. And please, I would like you to write down the stomatitis. What is the first sign that you can find in stomatitis? First of all, you need to be careful with oral care, right? So the pain and burning on the mouth, burning and pain on the mouth during the food, during the cleaning the brushing the teeth, etc. And it can be difficult swallowing because that produce pain. And they have other things like changes of taste, okay, and they have some cracks and fissures on the mouth. Just remember, these patients who have chemotherapy, their skin are going to be very sensitive, and the mucus too. So any fluid that can be cold is multiplied by 10 times colder. That is the feel how the patient is feeling. If the fluid or the food is hot, the patient is going to feel it like 10 more times hotter. So just be careful with that. And bone marrow suppression. Bone marrow suppression, they are going to destroy or depress what we call bone marrow suppression, BMS. They're going down the red blood cells, that is the erythropoiesis, plus going down the platelets, or plus going down the white cells. If the white cells go down, that means that the patient having risk for infection. If you have low levels of platelets, that means risk for bleeding. If you have the red blood cells going down, that means probably anemia. Okay? And the nursing consideration for each of them, the assessment and the nursing consideration. All right. So here we have small and frequent meals. Small and frequent meals. Why? These patients are going to have nauseous and vomiting. So what is the relation with the small and frequent meals? Nauseous and vomiting because if you have some big amount of food, that food is going to distend the stomach. Distending the stomach is going to stimulate the cranial nerve number 10, and that what is leading into nausea. The patient is going to probably still with nausea, but if you cannot totally get rid of the nausea, the best you can do is to minimize the nausea, right? Okay, so mostly of the time, when a patient is having chemotherapy, they are going to combine medications. And these medications are chemotherapies plus some corticoids. The chemotherapy combination, mostly what they are going to do is to be more effective to destroy cells that are dividing very fast. And that is directed to the cancer cells. But, it can be hurting the normal cells too. And corticoids are being used in addition. So corticoids is not antineoplastic, but we know that corticoids apply to patients who have chemotherapy. The effectiveness of the chemotherapy are going to be increased. Okay, for nauseous, we have the ondansetron, the serotonin inhibitor. Okay, they can lead actually into diarrhea or constipation. So either way, so it's not clear yet how is that happen, but it can be or diarrhea or constipation. Most commonly can happen with diarrhea. Avoid crowds. So why? Because you have depression of you have BMS, bone marrow suppression. You have lower white cells. You need to avoid crowds which can run some virus or some communicable diseases, right? Avoid cold, hot, spicy foods, and prepare for hair loss, all right? All right, so this is the three groups that we are going to talk, and here we have the antimetabolites, the mitotic, the topo isomerase, and the antienzymatic. If you can write down there, it's very simple. Antimetabolite is folic acid. It's going to inhibit the folic acid. Mitotic inhibitors is going to stop the mitosis. So we are talking about the cancer cells. Topoisomerase, so you know the cancer cells need to replicate, and the replication they need to uncoil, and coil again the DNA in order to make the replication. And this topoisomerase, what it's going to do is to stop that uncoiling of the DNA, so the cell will not be able to reproduce again. And the antienzymatic is going to be these names that we are going to see very brief. And this antienzymatic, what it's doing is to block the production of some essential amino acids. So if you block some essential amino acids, that means that the cell are not having all the tools in order to produce, for example, the wall cell, and that is going to make the cancers die. Folic acid, remember, is folic acid is going to be participating and promote the cell division. So we are going to give antimetabolites. So that means antifolates. Antifolates, that is going to decrease the divisions of the cell. And we have here, and I just put it here in yellow, what are the 1, 2, 3, 4, 5 medications that are high yield for NCLEX. We have the 5-FU fluorouracil, the methotrexate. We have the vinblastine, the irinotecan, and we have the topotecan here. So let me see if I go in the, okay, so let's see. I have some mistake there, so I'm going to just correct in the next slides. Antimetabolic, we have the 5-FU fluorouracil, okay? What we need to remember is the antidote, So 5-F-uracil, fluorouracil, can lead into diarrhea. You already know fast cells, right? Can be especially patients who have chemotherapy, they suffer from diarrhea, very common. And that the antidote is going to be the timidine. Methotrexate, the antidote is antifolic acid again. Okay, so methotrexate, so we already talked about fluorouracil and methotrexate. Antifolates, we have the fluorouracil and we have the methotrexate. So those are the main medications. And the antidote is the leucovorin. We need to remember that, leucovorin. Again, we have stomatitis. That is in general for all chemotherapies, and we already talked about that. Don't use aspirin because the aspirin can produce some factors that can produce destruction of normal cells. So we don't use aspirin here in the antimetabolites. Okay. All right. So bone marrow suppression and nadir. What is nadir? Nadir is, open eyes, open ear here, please, is the during the treatment is when the patient is reaching the minimum normal values of white cells. So that means 5,000, okay, white cells. So this is the nadir of the treatment. Here we have for mostly all the chemotherapies. Chemotherapies can lead into tumor lysis syndrome. In NCLEX, they are not going to tell you, okay, this is methotrexate. No, they are going to ask you in general, what is the tumor lysis syndrome? Of course, if you destroying the cells are going to have high levels of potassium in the cells. Remember, the most important cation in the intracellular is going to be potassium. Intracellular, so inside the cell. If you destroy the cell, the potassium is going out. So that is going to have huge amounts of potassium in blood that is going to lead into hyperkalemia. Remember the hyperkalemia mostly is going to be arrhythmias, right? Hyperphosphatemia, because this is the most common anion in the intracellular hyperphosphatemia. And we have again we have hypocalcemia, we can have hyperuricemia, and when you see hyperuricemia is because some proteins that are composed by purines are going to be coming out from the cell producing uric acid in blood. Okay, so the treatment for this is in this hyperuricemia is allopurinol. Interactions, we have methotrexate and aspirin, especially this combination. If you have methotrexate and aspirin, they can lead into increased toxicity of the methotrexate. So again, nursing considerations for general, for everybody, this is going to be a rule for everybody. Monitor hematopoietic function. Do not get any vaccinations without health provider approval because of the low white cells. Then we are going to talk about the mitotic inhibitors. Mitotic inhibitors, what is going to do is going to decrease, is going to stop the mitosis. We have two main things that we need to remember here. We have the vinblastine. Blastine is the stronger myelosuppressor. Blast, remember. And vincristine is the most neurotoxic. Okay? Neurotoxic, you know what is paresthesias again? Paresthesias are numbness, right? So those are the tingling, those are the main thing. All right, so here we have nausea, vomiting, stomatitis, BMS, alopecia, and lung toxicity. So here we have the mitotic inhibitors can produce lung toxicity. What is lung toxicity is the inflammation of the alveoli. So it's what we call pneumonitis. 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 Lung toxicity. Okay. All right, so let's talk about the topoisomerase, and here we have the topotecan and the irinotecan. This is very high yield in the irinotecan when they talk about antineoplastic. Irinotecan, I run to the can, right? So irinotecan, remember, I run to the can, and that means that I have diarrhea. So severe diarrhea, and that is a delay. A delay, please be careful with this, is a delayed diarrhea. So that means that you, after you take the irinotecan, and you can see the irinotecan is going to be intravenous, right? So mostly the chemotherapies are going to be intravenous. And this can appear after 2 to 10 days after you receiving the first dose of irinotecan. And that is called, because irinotecan is having a cholinergic effect, ACH, a cholinergic effect. So it's called a cholinergic diarrhea, irinotecan. Okay, so what we are going to give is anticholinergics, right? So as a treatment. So we have here irinotecan, I run to the can, diarrhea, cholinergic diarrhea. The proper name is the cholinergic diarrhea. It's a severe diarrhea. Mucositis is a general term that is produced the ulceration of the mucus of the GI tract. And the anti-enzymatic, that is going to be the asparaginase, pegaspargase, and the asparaginase. So that is going to stop the production of some amino acids in the cell. So that is going to stop the division of the cell. Okay, so just as a review here, we are going to see that first of all, the peripheral neuropathy. I'm going to give you some keywords that we always need to remember. For tuberculosis, peripheral neuropathy, so remember isoniazid is a cornerstone of all treatments, so you expect always peripheral neuropathy, nursing considerations, gives supplements of vitamin B6, the pyridoxine, and educate the patient to report any of these symptoms. Which one? Numbness, tingling. Okay. Remember the all antitubercular medications all of them are hepatotoxic. You need to have your lab test one or every 2 weeks. And remember, tuberculosis is going to last at the average is 1 year and a half, 2 years. 2 years is actually or 24 months is what you need to remember. We have different side effects. La rifampin is orange, yellow urine. Ethambutol is visual acuity, red and green visual disturbances. How we are going to check the effectiveness of the medication. The effectiveness of all anti-tubercular medication is based on the signs and symptoms. You decrease what we just mentioned, right? Fatigue, weight loss, fever, night sweats, and cough. So all these signs and symptoms are going down. Plus, you need to have a skin test again, and you need to have, X-ray if there is some how looks the lungs. All right, so just remember the rifampin, cow D, okay? Rifampin is decreasing the effect of the corticoids, decreasing the effect of OCP, warfarin, and digoxin. Another thing that we need to remember is the isoniazid is going to increase, so please, rifampin, decrease, cow, D, corticoids, OCP, warfarin, digoxin, and the nursing considerations. Now, isoniazid is going to increase the phenytoin. Phenytoin ends in IN, so INH, just to remember. And multiple drugs, you remember, are being used in what for? for the diminish the incidence of resistance of the bacteria. Okay. All right. So, talking about the cancers, just remember what is how we call epithelial cancers, connective tissue cancers, lymphatic cancers. Remember the 5 drugs that we was talking about, the 5-fluorouracil, the methotrexate, okay, and the irinotecan. We have the, what else we have here? The beam blasting, beam blasting and beam Christine is here, okay. So this is the confusion here. Please, is beam blasting and beam Christine. Beam blasting, blast means that is going to destroy is a more the one who produce more medullary suppression. And beam Christine, this is not irinotecan, so please delete that. Is beam Christine is going to be the one who produce more neurotoxicity, so paresthesias. And here in the topo isomerized, we have, yes, the irinotecan. The irinotecan, I run to the can. All right, so I think that is all about our review today. If there is any questions, please. Let me see. All right, so just a moment. Deepika, thank you so much. Shelny. Soli, can you hear me?
Yes.
Okay, so we finished. So if there is any questions, please let me know. And thank you for your attendance today. And please, I will just let me know if you have some questions by Thank you, Deepika. Thank you, Shelny. Thank you, Solimar. Have a good night. Thank you.
Good night.
Good night.
Good night.